area of reproductive health. So I'm glad to chair this session. And the four presenters we have, we shall start with Juliet Mongali. She's Kenya country, she's a project officer for Action Foundation. And I will kindly request her to spare about 30 seconds to do very quick self-introductions. I found it more comforting that way before we dive into details. And she has a pre-recorded video as well as the PowerPoints and audio. And the team behind will be supporting us in moving those pieces. So quickly, Juliet, go ahead and do a quick self-introduction, please.
Okay. Good morning, everyone. My name is Juliet Mongeli. I'm the Women and Girl Empowerment Officer from the Action Foundation. I am very privileged and humbled to be here today. I will do a presentation on the barriers to access to family planning services by women living with disabilities, and it's going to start with a short video. So thank you and welcome.
Kwa majina ni Priska Akumi, mkaaji wa Kibera line 7. Mimi ni mama wa watoto watatu. Nilifanywa kufungwa ambapo ni sterilization wakati nilikuwa najifungua mtoto wangu wa mwisho, na nikafungwa kwa kukosa idhini yangu. Nilijipata kwamba wameweza kunifunga kwa sababu nilipouliza waliniambia wamenifunga kwa sababu niko na ulemavu. Hiyo ndio sababu au kuamua ya kwamba waweze kunifunga. So kwangu haikuwa jambo rahisi, maana kama mama ilinidhalilisha upande mwingine.
I'm Elizabeth Akinyi. I'm physically disabled. In 2012, I went to a certain hospital to give birth. Then when I was in the labor room, doctors delayed to attend to me. So the child came and fell on the floor. Then she broke her lips. Then after that, the doctors told me that I gave birth to a disabled child because me also I have a disability.
So like you have heard from my two sisters, the first lady, Priska, after delivering 2 children, the doctors, without her consent and her knowledge, sterilized her simply because she is a woman with disability. Later on is when she came to find out that she was sterilized, and the reason was because she had a disability. The second lady, who is also physically handicapped, went to deliver a baby like any woman would. And when she got to hospital, she was already experiencing stigma due to her disability. When the time came for giving birth, the doctors did not attend to her. Eventually, the baby came out, fell down on the floor, and broke his limbs. The doctors, in their defense, said that the child did not break the limbs when he was born. They decided that the child was born with a disability simply because the mother also has a disability. Those, my dear, are the challenges that women with disabilities are facing in Africa, including myself. My presentation is on the barriers to access to family planning services for women with disabilities from the informal settlements of Nairobi. This is a qualitative study that was done by our Director of Impact and Learning, Madam June Omune, and co-authored by Maria Omare, our founder and executive director. So due to the nature of my disability, I request you to watch the PowerPoint slides, and I have a pre-recorded voice of my voice just going through the slides, and then I'm going to do a brief conclusion. So thank you and welcome. I request for the PowerPoint slides together with the audio description of the slides.
Women and girls with disabilities in informal settlements in Kenya face exclusion, discrimination, and stigma in accessing social services. According to 2019 Kenya's Population and Housing Census preliminary reports, there are 523,883 women with disabilities in Kenya. Data disparities exist due to fewer registrations, invisible disabilities,
stigma, low awareness, and inadequate training of census administrators on disability data collection. These data disparities have adverse effects in planning and service delivery to persons with disabilities, including sexual reproductive health, SRH, services, and unmet family planning needs. The Action Foundation, TAF, is a community-driven organization working in Kenya's urban and rural informal settlements to end stigma and discrimination against children, women, and girls with disabilities. In 2020, TAF conducted a targeted situational analysis in the informal settlements of Kibra to assess the experiences of women and girls with disabilities in accessing sexual reproductive health and rights, SRHR, services in Kibra, sub-county Kenya. We used the results to influence program implementation and design awareness-raising interventions targeting members of the community, including service providers and male change agents. Objectives. The main objective of the situational analysis was to establish the barriers women and girls with disabilities to access sexual and reproductive health and rights services, including family planning, in Kibra sub-county. Sub-objectives were to explore expressed needs of women and girls with disabilities regarding SRHR, to describe challenges and barriers that women with disabilities face in accessing SRHR services due to the access and use of these services, including gender-based violence. Establish available community support systems regarding SRHR and the role of different stakeholders. Methodology. In 2020, TAF conducted a targeted situational analysis by conducting focus group discussions and in-depth interviews in the informal settlement of Kibra 2, explore exposed needs of women and girls with disabilities regarding SRHR, to describe challenges and barriers that women with disabilities face in accessing SRH services, to the access and use of these services, including gender-based violence. Establish available community support systems regarding SRHR and the role of different stakeholders. The study was limited to adult disabled women in the reproductive age between 18 and 35 years living in Kibra with diverse disabilities including physical, visual impairment, and hearing impairment. The sample participants were selected from women with disabilities of reproductive age and excluded young adolescents below the age of 18. Women with disabilities above the age of 35 years were excluded as the project targeted female youth with disabilities. Participants were selected using mixed methods of convenience, sampling method, snowballing method, and purpose sampling of the female FGD participants. The risk assumptions in the situational analysis were that the selected women with disability had a shared perspective of the general population. The data was analyzed using content and narrative analysis methods. Key findings. The situational analysis unearthed key findings on family planning needs for women with disabilities in informal settlements. Poor accessibility of family planning messaging, e.g. difficulty understanding radio messages for people with hearing impairment, or TV, not captioned, or sign language for people with visual impairments. In addition, perceptions that persons with disabilities are asexual lead to withholding information based on the assumption that they do not need it. Participation in decision-making is restricted. Women with disabilities had little power and autonomy over matters affecting their bodies, such as child spacing and planning, and negotiating safe sex. These decisions were made based on a family's living conditions, income, religion, and the availability of modern contraceptives which are out of reach of PWDs due to their high costs. Many women face financial constraints that limit their ability to obtain contraception. The most common methods of family planning among women with disabilities are abstinence, the calendar method, and breastfeeding. Because of religious beliefs and financial constraints, they prefer to use traditional methods of family planning. Service providers force women with disabilities to take specific methods of family planning that do not work for them, denying them the right to choose. There is a lack of expertise around family planning programming from a disability perspective among service providers. Knowledge contribution. There is a need to educate women with disabilities on family planning and the options that exist to enhance informed consent to procedures. Providing family planning information in adapted formats ensures access to different types of disabilities, for example, visually impaired, hearing impaired. To counsel clients with disabilities, healthcare providers need to consider their preferences and the nature of their disability. For example, barrier methods may be difficult for some people with a physical disability, and women with an intellectual disability may have trouble remembering to take a pill each day or dealing with changes in monthly bleeding. Meeting and talking with people with disabilities can give providers valuable information about how to make services more respectful and accessible. To meet the family planning needs of women with disabilities, advocacy programs should highlight the barriers and challenges they face and create awareness of the different adaptations to be made to ensure access to family planning. There is also need to implement behavior change training among service providers on disability inclusion. Healthcare systems should make available a process for supported decision making. Someone the client trusts should participate and help to make it an informed choice that is as consistent as possible with the client's preference. It is necessary to subsidize the cost of modern family planning in order for more women with disabilities to use it on a regular basis.
So thank you very much. I hope we have followed through. We have gone through the background, and we have gotten to see how exclusion, discrimination, and stigma still remain factors and barriers that women with disabilities encounter to date in accessing family planning methods, how women are being sterilized without their consent and their knowledge, how the society, and including the healthcare providers, assume that as a woman with disability, I am asexual and unable to make decisions on my own, and how we can include inclusion as we participate and advocate for SRHR, and inclusion as we innovate, accelerate, and celebrate. Thank you very much.
So thank you very much, Juliet, for your presentation. Very well timed. And again, the questions will be asked subsequently after all the presenters have made their submission. I now go ahead and call the next presenter, Mr. Monge Magoma from Tanzania, country representative in gender, and he will quickly give us a quick introduction, self-introduction, and then.
Well, thank you so much, Freddie. I am Moke Magoma, the country representative for Gender Health Tanzania. My background, I am a medical doctor, specialist in both public health and the clinical with OBGY specialization. Thank you so much, my sister Juliet, and allow me to share some of the solutions to what you have just explained. I will be sharing experience on ensuring inclusive and integrated family planning services for people with disability in Tanzania, sharing specifically successes and the challenges. Yeah, I am presenting on behalf of my colleagues, as I highlighted there. The results or the data I'm presenting are from a project called Scaling Up Family Planning in Tanzania. It's funded by the Foreign Commonwealth and Development Office and implemented by a consortium led by Gender Health. Other consortium members is the Comprehensive Community-Based Rehabilitation Tanzania, CCBRT, DKT International, and Pathfinder. Pathfinder oversees the young people inclusion, while CCBRT is responsible for the people with disability component, and DKT procurement of essential commodities. Yeah, allow me to start talking briefly of Gender Health. It's an organization that believes in partnership. We partner with governments, communities, and people to ensure that SRH services are provided. We go further to ensure that we reach remote and marginalized communities, to ensure
pour nous assurer qu'il est
and through that we ensure service inclusion. And I invite you all to follow us on that path so that we address some of the issues my sister Juliet just highlighted. That's how my presentation is arranged. Yeah, in Tanzania, it's estimated that around 9% of our people are people with disability, yet just part of the systemic challenges, as my predecessor, my sister Juliet mentioned, the system doesn't collect any information on people with disability. And capturing this information as a program, we are using program-specific tools. And as I mentioned earlier, I'm presenting data from a project called Scaling Up Family Planning. We work in around the 545 health facilities across Tanzania with the focus of ensuring provision of inclusive and integrated services for people with disability. Just to describe briefly our intervention, in collaboration with the Ministries of Health, for those who will know, Tanzania is divided into two parts. We have Tanzania mainland and Tanzania Zanzibar. Both parts of the country, they have their own ministries. Therefore, the reference of ministries here. We worked with the two ministries to orient service providers and the community health workers on the concept of disability inclusive services using the government-approved training curriculum as an addendum so that providers have the necessary skills to provide inclusive services. We are also enforcing strictly the concept of safeguarding across all service delivery models, service delivery levels, to ensure that inclusive services are provided. We also monitor and evaluate our activities through tracking of what we do. In this case, inclusive services for people with disability. We have been doing this for 2 years, and through that, we have identified successes and the challenges, as I would share with you shortly. The methodology we used, I'm presenting data from our program for the period of February 2020 up to December 2021. And I have mentioned this, that we are using a paper-based monitoring tool as the existing national HMIS system doesn't capture this information. We capture information on age, previous use of contraceptive method, and the disability besides others. We determine a client as someone with disability by applying a stringent classification criterion. For those who understand the Washington criteria, you have several criteria, but for us, we are becoming stricter, and we reached this level through consultative discussions across the country, including across people with disability organizations, to agree as a consensus what level of disability may affect someone from accessing services. and we chose having a lot of difficulties or being unable to do that. We have also added other forms of disability which are not within the Washington group criteria, such as albinism. As a country, we had the notoriety of people with albinism being killed some years back, and we took it as a disability because they are likely to be discriminated when they seek services. We did collect both qualitative and quantitative data. For the qualitative data, we did key format interviews with 40 purposely selected service providers. During our support supervisions, we conducted around 133 support supervisions during these visits, and we used a semi-structured questionnaire. And we analyzed this data using a thematic-based analysis, while for the quantitative data, we use this data. Allow me to share with you some of our results. As you may see, close to 48% of the people with disability we reached during this period were either physically impaired or deaf, and that we reached slightly over 6,000 people with disability during this period, who presented around 0.9% overall of all our clients. And for the individual years, is highlighted on the slide on your right. To share the successes we have achieved this far, we have demonstrated increase in sexually reproductive health service uptake by people with PWD, as captured by the quote on the right. We have also managed to amplify the PWD agenda across various levels to ensure that they are included in various levels of service provision and oversight, as well as administration. And to celebrate our work, together with the ministry, we recently included a special section in the national guidelines and standards on people with disability, so that service providers who will be trained from henceforth will be introduced to the concept of inclusive services, including for people with disability. Yes, we have had challenges during this period. I mentioned it earlier that our national health management system doesn't capture information on people with disability. We are using our own tool. And the second challenge is that still we have few service providers trained on inclusive services. We need to train more as a country to ensure inclusive services for all. And another challenge, cost may be prohibitive for people with disability. At times, much as services are there, they need to travel from one point to another for these services. If they don't have fare for transport, they may not access the services they need. What are the reasons or implications to share with you? The evidence I have just presented show that more equitable and inclusive sexual and reproductive health and rights is possible with good policies or supportive policies and programs. We have managed this because we have worked very closely with the Ministry of Health, being guided across, including the use of the tools we have developed. We have also shown, much as the system doesn't capture this information, that is feasible. And that, if possible, having field evidence gaps related to PWD from periodic assessments can be key to understanding more how people with disability fare with available services. And I mentioned the shortage of service providers, especially those trained in inclusive services. And its solution may be introducing training of these service providers on inclusive services during pre-service training. this is imperative for the country to move forward to ensure inclusive services. And to mention, lastly but not least, that we are also monitoring method choices among PWD, and will be reporting this periodically to various forums within and outside the country as a quality measure to ensure that method choices are respected. Thank you so much for listening. You can contact me through that email. We are located booth number 63. You can get more information on our work, or you can even visit our microsite as highlighted there to access my presentation. Again, thank you so much.
Thank you so much, Dr. Wangoma, for that presentation, which addresses important issues, including ways how to deliver to the people who are differently abled. So our next presenter is Thim Kabo from Planned Parenthood of Sierra Leone. Please move forward.
Good morning, ladies and gentlemen. I bring you greetings from Sierra Leone. I'm here to share my experience in working on sexual reproductive health, of people with disability. On the background, let me just throw a brief SRH contextual context in Sierra Leone. Sierra Leone has 7.1 million people with 717 per 100,000 life births, 717 per 100,000 life births, and 20% of those are contributed by teenage pregnancy. 10% contribution to maternal mortality is as a result of unsafe abortion among adolescents. The doctor to people ratio is 0.2 to 10,000 people. 0.2 doctors to 10,000 people. Midwives and nurses is 1.7 to 10,000 people. Sierra Leone is among the 3 countries, Niger and Mali, that are having the worst maternal mortality in the world. Ladies and gentlemen, my name is Thim Kabo. I'm the Director of Programs of the Planned Parenthood Association of Sierra Leone. Now, the Planned Parenthood Association implemented a pilot intervention project for people with disability in Moyamba district on the project Scale Up Access to Integrated Sexual Reproductive Health for young people, for girls and young people in 5 chiefdoms in Moyamba district, the southern region of Sierra Leone. This project was funded by the Japan Trust Fund through the International Planned Parenthood Federation. And this is a 24-month project duration period, Ladies and gentlemen, the goal of the project was to improve access of sexual reproductive health while contributing to the reduction of HIV and AIDS and sexual gender-based violence in the 5 project chiefdoms. The first objective is to empower 30,000 people with information and education so that they can be able to reach out the services through demand creation channels. The second objective is to increase access of 30,000 people is to increase the access of 30,000 women and girls to sexual reproductive health services. Let me share some of the key achievements that the project made while promoting inclusivity. The project provided 61,900, about 62,000 information services, of which those information services were accessed by people with disability. 3,040 of people with disability access the services, and of the information services, and The projects provided 36, the project provided 51,462 services to 36,186 people. And 1,195 people with disability accessed 3,983. And among the other key achievements were that 40 health service providers were trained in the administration of sexual reproductive health services. This includes the administration of long-acting reversible contraceptives. 10 youth-friendly facilities were equipped with information, education, and communication materials. These include traditional musical instruments, mobile PA systems so that they can promote demand generation, peripheral health units, which are partners in this intervention, we are given medical supplies. And these medical supplies were meant for the treatment of sexually transmitted infections and for the treatment of minor ailments such as malaria, fever, post-abortion complications, side effects in the uptake of family planning methods. The project also implemented 510 outreach sessions. It's supposed to have implemented 768 outreach sessions, but there were limitations caused by the COVID pandemic. Ladies and gentlemen, the project targeted people with disability, mobile impairment, but we categorically targeted those women and girls in wheelchairs. The reason being that women and girls in wheelchairs are discriminated by their family members. And when they are discriminated, resulted to 95% of them not being to school. So resultingly, they were unable to acquire livelihood skills. They were unable to acquire formal education. So they were unemployed. And that resulted them to going to begging for survival. And when begging fails, they resort to transactional sex, often unprotected. And the transactional sex, often unprotected, resulted to negative SRH, sexual reproductive health outcomes, such as unplanned pregnancy, such as unsafe abortion, such as sexually transmitted infections. But all those were responded to by the outreach services and the connect with peripheral health units. All those the SRH negative effects were treated freely by the project. But ladies and gentlemen, why again the principal reason for targeting these people in wheelchair, within the period 1970 to 1980, there was an outbreak of polio infection in Sierra Leone. So most people that were born within that period were infected with polio. So that is the reason that caused the large number of people with disability, especially those special group we targeted in Muyamba district. Moving forward, to work with people with disability, the project put in place certain strategies. One is to sensitize. Sensitization was done to create an enabling environment for people with disability. Then, moving forward, we signed a memorandum with the Disability Rights and Inclusion Movement. In fact, we signed a memorandum with two marginalized organizations. One was the Disability Rights and Inclusion Movement, that is the coordination body of people with disability. Then we signed a memorandum with the Voice of Women, the female wing of people living with HIV. Again, the third strategy was to bring these people together. People with disability and those without disability were brought together. There was a mix. Then we trained them as community-based service providers. We established 10 groups, 5 women groups and 5 girls groups. Those groups were brought together. It was a combination of people with disability and those without disability. But the community-based service providers that we are trained, 18 of them were people with disability. so that they can provide community-based services for those without disability and those without disability. Bringing people with disability and people without disability, it increases the visibility of people with disability at community level, because we know normally these people are discriminated and they are stigmatized. They are discriminated and stigmatized, and the discrimination begins with their people, family members. And that is what is responsible for the condition in which they found themselves. So in order for us to enable both of them, the people with disability and those without disability, to work together, is to reduce the barriers of stigma and discrimination. That is, we do sensitization within the project groups. Then again, we did sensitizations at community level through drama performances, through jingles, and other forms of sensitization. And interestingly, the people with disability, they were part of those that were conducting the drama performances at community level. So that enhanced the reduction in stigma and discrimination. Ladies and gentlemen, resultingly, the outcome was that it created demand of sexual and reproductive health services, including family planning methods, to people among disabilities. Then it promotes an understanding of people with abilities, of people with disabilities and their needs. It creates an understanding of people with disabilities among people without disabilities. There is a mix here. People with disability and those without disability, you have to create a synergy. And one way, when you create this synergy, one way is to do sensitization so that you can reduce the barrier. So people without disability can be able to understand the needs of people with disability. So what happened was that there was a high level of interaction between people with disability and those without disability. Now, the people with disability became community-based service providers. They begin to make changes in the community. They begin to make changes. So the projects observed that an improved understanding of the sexual reproductive health context by people with disability will increase the uptake of family planning methods among people without disability, and increased understanding of the sexual reproductive health context by people with disability. It can increase the uptake or the service provision of people with disability among people with disability. With adequate training, people with disability can become champions. They can become advocates and lead agents in advocacy, in community mobilization, demand creation, and in the provision of short-term methods. They provide short-term family planning methods. They do demand creation by giving out information and education. They, at the same time, they do referrals. They refer people without disability and those with disability for the uptake of long-acting and reversible contraceptive methods. They do referrals to address post-abortion complications. They do referrals to address side effects in the uptake of family planning methods. Ladies and gentlemen, the powers of people with disability cannot be underestimated. If they are trained and given the right direction, they can deliver results. So, resultingly, at community level, people without disability begin to receive services and accept services from people with disability. Initially, there was a discrimination and stigmatization, but after the mix, after the inclusivity, there are now people with disability, without disability begins to receive services from people with disability. Next steps. Ladies and gentlemen, we want to share this best practice with the world at the global development platform. We want to seek resources for people with disability in other parts of the country so that other parts of the country could be addressed with similar strategy. Then we plan to address the SRH needs of people with other forms of disability. We want to share the best practice. We want to seek resources for people with disability so that other parts of the country can benefit from this intervention. Then we want to plan to address the SRH needs of other people with people with other forms of disability. I thank you all for listening. Quickly, ladies and gentlemen, you can get us on the IPPF, www.ippf.com platform. www.ippf, International Planned Parenthood Federation, or JTF, Japan Trust Fund, or Planned Parenthood Association of Sierra Leone. I thank you all for listening.
So thank you very much, Dr. Kambo, for your presentation, empowering people with disabilities to provide the service to their counterparts, but also those who do not have these disabilities. Our last presenter is Dr. Pesta Silaha, and she will go ahead and make her presentation so that we can go into, from Population Services Zimbabwe, that we can go ahead and get the questions, comments, and discussions. Thank you very much, please.
Thank you. Morning, ladies and gentlemen. You've heard Pesta Siraha, the Country Director for Population Services Zimbabwe, a public health practitioner for more than 20 years, passionate about women and girls, access to services for the vulnerable communities, access to SRHR services. I'll be talking about increasing access to family planning for people living with disabilities in Zimbabwe. So in Zimbabwe, people with disabilities, they face a number of complications and channels, and they are vulnerable to services as they cannot access services easily compared to other people who do not have disabilities. 9% of the total population are people living with disabilities, which is 1.2 million of the 16 million population in Zimbabwe. And women are disproportionately impaired, with 9.4% living with disabilities compared to 8.5% males. And disability status actually intersects vulnerabilities, particularly also living in poverty, with 74% of people with disabilities are in poverty compared to 69% for those who are not disabled. And 32% are in extreme poverty compared to 28.5%. Access to contraception for people with disability was low, with only 4% of Population Services Zimbabwe clients indicating having a disability in 2019. And very few studies have been conducted on SRH among people with disability, and very little is known, as you can see that we are all talking about people with disability. And I'm also showing the map where Population Services Zimbabwe is providing services in Zimbabwe through its channels of service delivery, MS ladies who are the single providers, public sector support, static clinics, and outreach. So let's look at what is the problem, what are we trying to address? So there was a baseline study which showed that people with disabilities face multiple barriers to access essential healthcare services. And some of the barriers have been highlighted by my fellow colleagues here, looking at the physical barriers for people with physical disabilities to access the services, non-friendly infrastructure. We're also looking at stigma and discrimination, attitudes, cultural beliefs. I think my sister who presented the first was talking about the cultural attitudes and which are faced by people with disabilities. The health service providers are also not left out in those attitudes and behaviors. There are also communication barriers. I think my predecessors have also talked about the communication barriers. The providers are not able to communicate effectively with people with disability. And only 4% of the PSZ clients had a disability in 2019, and with a national disability of almost 10%. So what is our question? Does disability-friendly information, dissemination, and service provision increase people with disabilities access to full range of SRH and FP services? So specifically, we are looking to determine the proportion of clients taking up a family planning or an SRH service. We have a disability, looking at 2019 and 2020, and then identify the types of disabilities amongst the PSZ clients taking up FP SRH services in 2019 and 2020. Let's look at the interventions. So we had the initial intervention in 2017 and 2018 in all the provinces in Zimbabwe, looking at increasing awareness of a full range of FP services, increasing service access for people with disability, strengthening the capacity of people with disability service providers through training to offer disability-sensitive counseling, treatment, and care. And then targeted evaluation was done to ensure adapted programming for people with disabilities through our client exit interview, which was done in 2019 and 2020. So what is this client exit interview? This is a tool for understanding who our clients are as part of the global MSI. What are the services and the experience of the clients? So we look at the client's journey, evaluating and assessing the client's journey as they come to seek our services. PSZ has been delivering these client exit interviews for the clients for over 5 years on an annual basis. And this is a way to try to understand our clients and their experiences so that we can provide the services or adapt our services better. So 40 to 50 minutes face-to-face interviews are done and administered to a random sample of SRH clients as they exit or enter the MSI services. PSZ is also part of MSI. I might have omitted that as I started. And then the survey covers the following areas: the client demographics, the previous FP use and fertility intentions, the quality of care, client experience, and how did the clients hear about us, and the disability status and the poverty status. So what then are the limitations? The survey was not developed to specifically evaluate the interventions, not the specific needs and experience in this client age group. Small sample size, it was not a very big size, not powered to detect small changes in rare outcomes such as disability, and cross-sectional surveys conducted over a short period of time. A non-response was not captured. Clients with a disability could be less likely to participate. They could just not be very much willing to participate as they might foresee stigma. And survey submitted in multiple local languages. There are multiple languages in Zimbabwe, which might make it the interpretation a bit biased. So a cross-sectional client exit interviews were done 2019-2020, and the setting was the PSZ clinics, the mobile clinics, and the social franchise. And the sampling was done on strata using the static clinics, also using the census data. And then the participants, sample size of 763, and data collection on electronic data collection system, and descriptive statistics analysis was also done. What are the results now from these interventions? So between 2019 and 2020, the proportion of clients reporting they have experienced a lot to complete disability increased from 4 to 10%. So we were like similar to the national statistics of 9.4%. And across both years, mobile clinics had the highest proportion of clients reporting they've experienced some to complete disability. So what is peculiar about the approaches we used is that we used the Washington group of questions, where the client actually reports themselves that they do have a disability. Instead of you looking at the client saying, no, this one has a physical disability, but there are certain disabilities which are self-reported by the client. So we thought this was quite helpful as the client will actually report themselves. And there we are also representing the increase in the number of clients that reported that they had a disability. If you look at the static clinics, there's actually an increase across static clinics, mobile outreach, and social franchise. So trying to understand the type of disability, as these were like self-reported types of disability, I'll just highlight a few areas there. On vision in 2019, there was an increase from 31% to 36%. Clients self-reporting that they do have a problem with vision. Because vision, most of us do have challenges with vision, but the ability to say, I do have a disability at times becomes a challenge. And then mobility, we can see that also there was an increase in the number of clients reporting that they have a challenge with their mobility. This is just a client self-reporting that I have a challenge with mobility. So what then are the implications of these interventions and our findings? So we have noted that strengthening partnerships, I think there was discussion about partnerships from IPPF with the Federation of Organizations of People with Disability in Zimbabwe, FODPIS. This is an organization for people with disability, and other civil society organizations in the space is best to understand how to reach and how to support them, so that partnerships and collaboration. Facilitating disability audits as an organization, and then we went on to launching the diversity, equity, and inclusion diversity strategy, DEI strategy, to ensure inclusive participation of people with disability and having their needs catered for at every level in every unit of the organization, from the service providers, recruitment, and they're also involved in decision making. So we recently promoted an employee with a physical disability. To us, that was a plus, because we didn't have that kind of a cadre, and we recruited that employee who is now coordinating one of our channels, the outreach, and he's doing very well. We are quite impressed. And inclusion of people with disability indicators in all our grant proposal or fundraising activities, and including people with disabilities even in research. And we even translated our IEC materials into Braille with a large print, so that they could easily are able to read, and incorporated sign language into video and social media, information dissemination, education, and communication. And we signed up as a member of the technical working group for people with disability in the country. Then what are the takeaways from this? So disability inclusion within the project planning, implementation, monitoring, learning, and evaluation is a direct impact on the number of people with disability accessing our services. It is crucial to include disability inclusion with activities within a service provider training. I think somebody talked about training here, and ensure referral networks are created for people with disabilities, so they know where to go, they know how to access these disability-friendly services. Family planning programming should consider providing SRH, FP information in pictorial, sign language, Braille, in order to cater for all persons across the spectrum of types of disability. This should not wait for special funding to be incorporated. I think somebody talked about mainstreaming disability in our programming. Effective program implementation requires that people with disability are actively involved in the whole project cycle, from project conceptualization, monitoring, evaluation, where they define together the FP indicators and improved FP service outcome. It is therefore imperative that FP service providers are trained on disability-sensitive service provision, especially the counseling part, as best practices for any FP-related program. I thank you very much.
And again, so thank you so much for the great presentations that you made. Very unique and important, certainly, and issues that keep coming up, empowering people who are differently abled in all various aspects of our daily lives, and also including them as potential actual service providers, not only to themselves, but also to the other members. I'll go ahead and call upon the presenters to take up their seats. I guess three can go ahead and sit there, the other can sit with me, so that we can have the mics. I'll ask the members on the audience to raise comments, questions, suggestions on how, and lessons learned, and see how we can manage the next 20 minutes of this discussion. So you're welcome. So I think I'll take questions, comments, anything, three of them, and then we shall keep doing so. Yeah, please go ahead. I think there are mics in the aisle. And it may be nice to possibly let us know who the question is being directed to, if possible.
Okay, thank you so much. Thank you for the nice presentations that I was been following. My name is Zakia Musa Ahmed. I'm from South Sudan. I am a visual impairment lady. I work with humanity and inclusion in wish to action as a reproductive health officer. My question want to go to the speaker from the Tanzania. And for sure, I like his presentation because it was so excellent to me. And even some of the experience, I already took it. I'm going to integrate it into our work as people from South Sudan. But the only things that I want him to clarify to me, because they have did actually an excellent job, especially they have been able to do their own to capture the number of persons with disabilities. What I want to know in their policies, is in their national health policies, do they have a specific session that can address the issue of inclusivity? If the section is there, why the national health management is becoming challenging for them to capture the number of persons with disabilities, according to what he has been presented. Then two, because I have two questions, sorry. My second question, I realize in some other countries, especially the country where I'm coming from, we are able to integrate persons with disabilities to be part of the community health workers or as a village health committee. Do they also have such kind of experience there in Tanzania? If this is what I want to know, can him share for me? Yeah, thank you so much.
So thank you very much. Next question. Yeah, again, there are mics in the aisle, please.
Thank you, everyone. Thank you for the presentations. And I think the research are amazing. You are doing a good job, and we give a thumbs up to each and every work that is going outside there. And also my question, I think, is similar to what my colleague is asking. My name's are Phyllis Mbeke. I work with Women's Spaces Africa, a feminist disability-led organization working with and not for disability. And my question goes to the Tanzania presentation, and you're doing a lot of good work with people with disabilities. However, I did not hear how you've integrated disability in your work. You're working for disability. How have you brought on disability on the table? For example, in designing the innovations, in monitoring and evaluations, even in assisting in resource mobilization. Sometimes we know our needs much better than other people know our needs on our behalf. To the Sierra Leone presentation, thank you so much. The IPPF is doing a good work. I would also want to know how you're including disabilities in your innovation. Are we part of the researches you're doing, or are we just beneficiaries? The same goes to Tanzania. Are we part of the interventions and the innovations, or are we just passive beneficiaries? You know, sometimes when we do some of these innovations, they promote more egoism and more of othering and not more of inclusion. Thank you.
Thank you. The last one for this first round, please.
Hi, thank you so much. The presentations were excellent. My name is Sarah Rich. I'm with the Women's Refugee Commission based in New York. My organization is partnering with local organizations in Sudan and Pakistan to launch new programming, including programming that's aimed to be inclusive of people with disabilities. And I wanted to ask the presenters if you could share more about the training materials that you used with service providers and community mobilizers alike, and whether your organizations developed those yourself, or whether you used or adapted other internationally used materials, and what your recommendations would be for the best materials that are currently available. Thank you.
Okay, thank you so much. Let us first hear again responses to this quickly, and then we go for another round. Anyone can start, please, go ahead.
Yeah, thank you, my sister from South Sudan. Regarding the tools, the HMS tools, yes, as I mentioned, Tanzania, the routine HMS tools do not capture information on people with disability. However, just going further to answer another question, it doesn't mean that there are no support systemically for people with disability. There are. I was just alluding to the HMIS tools. If you attend services to people with disability, that at the end of the month or end of the quarter or end of the year, somebody can analyze and say, this proportion of people who sought services at our facilities were people with disability. That hasn't been made yet, but it's in the pipeline. The ministry is working on it. The challenge has been finding a space within a crowded system to include new indicators. But as I mentioned, we have been able to include a section in the training of all providers and in our guidelines, how to ensure inclusive services. And for the training materials, please, there is my colleague, Freddie Msigara, seated behind. You can contact him. He can share with you the tools we are using. Whether PWD are engaged, I think I have just answered that. Freddie is leading the PW component. He was there at the conceptualization of the idea, writing the proposal, is there implementing, evaluating the progress we are getting. So this is a very inclusive designed program to benefit PWD in our country. Thank you.
Sila, okay, please go ahead. Next.
Thank you very much, Sarah, for the question on the training materials. I'll just respond on that one. So for PSZ, we were actually trained by people with disabilities themselves. So they came in with the training materials and trained all of us. All the Braille, we didn't understand it, so they also helped us to try and understand what it meant. And we ended up producing a family planning manual, which was in Braille. We have counseling guidelines, like this. So you open like a flip chart, so which were also in Braille. So that really helped us to communicate, and also helped the people with disabilities we were working with, as they'll also be providing counseling services to their colleagues. Our IEC material was also translated into Braille. So yeah, that's what we did in order to try and communicate.
Thank you very much for your questions, ladies and gentlemen. For our own intervention, working with people or working on sexual reproductive health of people with disability, the tools that we used were, one, we have the participatory learning action tools. Participatory learning action tool. I can give it to you if you contact me outside. I will give you the soft copy. It's a 91-pager self-learning application tool. Then we use life skills manual. Then we use comprehensive sexuality education manuals. Then additionally, we train these people with disabilities in the use of, we train them as social media influencers, in the use of social media applications for information and referrals. Then in terms of inclusivity, in my presentation, I mentioned DREAM, Disability Rights and Inclusion Matters. That is the coordination body of the people with disability. We were working with them. We even signed memorandum of understanding with them, right? Then I also mentioned that we signed memorandum of understanding with the Voice of Women. Voice of Women is the female wing of people living with HIV. Thank you.
Okay, sure. Thank you so much. Can I have another set of questions in the remaining minutes? Please, in the aisle, and then the next gentleman after you.
Yeah, thank
You're
you.
number 2, 1, 2, 3. Yep. So.
Yeah, thank you. I just have one question for Sierra Leone. My name is Fortunate. I work for Handicap International. As I was following your presentation, it is looking at targeting one specific impairment group, that is the physical impairment, both women and girls with the physical impairment. However, if you look at the SRH needs, it's covering and cutting across. I do not know if it reflects the demand of the objectives of the project, but what are the plans for the other groups, those with the visual, and then also as well as the other impairment groups? Thank you.
Thank you. Frederick?
My name is Frederick. As I've been introduced, I work together with Dr. Moke. Mine is not like a question, but rather to like add more to what Dr. Moke has said. In terms of implementation, I'm the one involved in the implementation, and I'm the one doing the training to healthcare providers. With regard to what are reference materials that we have used to develop the addendum for the training, we have the UN Convention on the Right for People with Disability, and we have the Disability Act in Tanzania. Now, from those documents, that's where we came up with the material for the training. There was, in the presentation, something highlighted awareness raising to people with disabilities on the availability of the disability inclusive sexual reproductive health care services. That's very important. You may, come up with the inclusive program and train your healthcare providers, put everything in place. But people with disabilities, if they are not aware of the availability of those services, they will never come to the facility. So there is a need to create awareness among people with disabilities on the availability of those services and encourage them to access. In our case, whenever we have platforms where we meet with people with disabilities, we always inform them about the program and the services that we provide. And when they have events like marking International Disability Day or other platform where people with disabilities are there, then as program implementers, we are there to inform about the program, but also to provide services to people with disabilities. There was one barrier that was highlighted, transport being a barrier to access, sexual reproductive health care services. Actually, it's not just like transport for you, for a person with disability himself. There are people with disabilities who need assistance when they are going to the facility, and they have their personal assistant. And they are the people with disabilities who have to pay the cost of their personal assistant. So if the cost for a person with disability to access healthcare services is much more higher than for a person who is not having a disability. And the other thing I would like to highlight here, that outreach services we've learned from our program, they can play a significant role in terms of addressing the access barriers of SRI services to people with disabilities. Outreach services, you bring the services closer to the people with disabilities, and therefore you have reduced the cost of transport, but also save the time of this client of coming to a distant place to get the services. So these are the issues that we need to look at when we are talking about disability inclusive sexual reproductive health care services. I just wanted to add those few points with regard to inclusion of people with disabilities in sexual reproductive health. Thanks.
Thank you, Frederick, for those great additions and clarifications. Okay, after her then, just please.
Okay, thank you. I thank all the three presenters. My name is Fikirta. I am from Ethiopia, and I feel that the landscape we live in are similar.
I think you are not using the mic, it seems. Are you able to hear? Okay.
Okay. You hear me now? Okay, my name is Fikirta. I am from Ethiopia. And I thank all the three presenters, and I feel that our landscape is the same related to the experiences of access to SRE services by persons with disabilities. My first question goes to the first presenter, and the forced abortion, sterilization without consent, and giving specific kind of services for women with disabilities is very common, as you said, and it's also practiced in our context. And sometimes I feel that it's not about awareness, rather it goes with professional ethics of the professional, the health sector professionals, and how best can we challenge this issue to get a solution. And the second question goes for the Tanzanian presenter, and you have mentioned that the health management information system that your ministry is using is not disability responsive, and you have used your own tool to collect data. What are you doing to ensure sustainability of the system, just to make sure that the tool that the ministry is using becomes disability responsive, so that it can be sustainable for any other time? Thank you.
Okay, thank you. The last comment, please. And I guess presenters prepare to make your feedback. We have about 3 minutes to go.
Thank you. I wish also to commend the presenters who shared with us the good practices. I have one question to the presenter from Zimbabwe about how they have used sign language, specifically on the people with the deaf or hearing impairment. How did you work with them, or how are you working with them to ensure inclusivity, especially those who can't hear? The other one is just a comment to learn from all the colleagues who have presented. That my name is Peter Owaga from DSW Tanzania. We work with young people. So one thing that we learned in the process of working with young people is that also the young people with disabilities is also a very important segment of our community. And they also deserve to be given services like other young people. So one of the first lessons we learned as an organization in Tanzania is when they need services. And I'm very happy that we have champions like Freddie, who has also supported most of our organizations on how to work with the people with disabilities. So we looked at the issue of the infrastructure within the facilities, within the offices, which was okay. But then we faced another obstacle on, again, when someone came to the office and said, I'm a young person, I also deserve to get services as a young person because we work with young people. Then we kept also learning that it is a diverse field that we need to learn as we progress. So like our colleagues in Zimbabwe, all their staff were trained on sign language. So the issue I have here is, I would wish also to look at specific disabilities so that we don't spread ourselves so thin. So if you think you're very good to work with the deaf, and there is a complementarity, then that would be very good. So I would just want to learn which specific target group do you work with in the different countries on disabilities? Okay. And do you specialize, and do we need to specialize? Thank you.
Okay, thank you very much. Each presenter, only 30 seconds. We are timed out. Please, quickly. Juliet? 30 seconds.
So thank you very much for your question and your remark. It is true that it's an issue of ethics, but sometimes our healthcare professionals do not uphold their ethics. So what we try to do at the Action Foundation is we do a lot of advocacy and awareness creation on the rights of women living with disability, that they have rights over their bodies and agency and autonomy. So we just make it, we just create awareness that Juliet, as a woman living with disability, I'm able to make a decision on my own, and I have a right on my body. Thank you.
Thank you very much. The other colleagues, quickly, 30 seconds.
Yeah, on the tools in Tanzania, we are at the advanced stage of accommodating a section of people with disability in our tools. It starts with someone, thank God, with the stakeholders, and the government has been quite listening. They are seeing a possibility of including PW component in our tools. By the way, for some components, they have just introduced it. For GBV, for example, now that part captures information with people with disability, it's disaggregated across types of disability.
Okay, thank you very much. Zimbabwe and Sierra Leone, quickly, 30 seconds.
So
please.
on sign language, again, we were trained by National Association for People with Disability in Zimbabwe on the standard sign language, which was acceptable. So we later on learned that sign language can vary, but we then looked at the standard sign language, and they came and trained us. And then they did disability audits, and this included a number of areas, like all our signs should indicate, like if there's a toilet, instead of writing, what sign do you write? Or a number of areas which were covered during the audits, and then we responded. It's a work in progress. We can't say we are there as yet, but we are working to try and include some of the recommendations from the audit.
Okay. So thank you so much. Very quickly.
Thank you very much for your question. In my presentation, I mentioned that working with people with disability is a pilot in the implementation of that 2-year project. And our theory is to plan, intervene, then we consolidate before we move forward. Okay. So that is why we decided to work with people with these women and girls in wheelchairs. On the background, those are people who were victims of the 1970-1980 polio outbreak, and they have been discriminated by their family members, so they are potential target beneficiaries.
Okay, so thank you very much, presenters, and thank you very much, listeners. We know you're going to work on our policies. It's very important. Community engagement, providers without discrimination, and eliminate stigma. So thank you very much for listening, and I hope we can move from here, boardroom, to more action. Thank you very much for listening, and have a great afternoon. Thank you very much, Juliet. It was a nice one. Yeah, thank you. It was very beautiful.